This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. We have a 74-year-old lady who has this long-standing cataract which has resulted in a lens-induced glaucoma. This is a phacolytic variant, and many of you would not have seen something like this. This is a lens matter in the antechamber and looks like a hypopyon. It's called a pseudohypopyon. It's nothing but a leak lens matter through this lens capsule in this Morgagnian cataract. Obviously, the patient would have severe pain and bouts of vomiting, and we need to do the surgery, but before that we need to control the pressures and the inflammation for a couple of days, and then surgery needs to be performed. On the day of the surgery, the pressures are under control, the patient has been given IV mannitol, and surgery is being done under peribulbar block. The major challenge which I'm anticipating in this case would be whether I'll be able to preserve the bag, because I expect significant amount of zonular weakness in this patient. Although I am ready with the capsule fixation devices, I am also ready with an iris claw lens that in the event the bag is extremely loose and the zonules are very weak, then I'm going to perform an intracapsular extraction and then place an iris clip lens. Of course, I'll be also doing an anti-vitrectomy, and let's see how things turn out. So I begin by creating two side ports. I just go in with my bimanual I&A and remove all the leaked lens matter in the antechamber. The visualization improves. The capsule is stained, and I just want to see how good or how bad the zonules are before planning my incision, because if the bag is healthy, maybe I would consider phacoemulsification in this case. As soon as I puncture the capsule, the liquefied cortex comes out, and I'm going to use a bimanual I&A to just evacuate the antechamber of all the leaked lens matter. At this stage, I'm not convinced that it is safe to do phacoemulsification in this eye, so I decided to perform a manual small incision cataract surgery in this patient. So the chamber is filled with OVD, and now is the time I'm going to raise the conjunctival flap. The conjunctival flap is raised, the epithelial bleeders are cauterized, a 7mm scleral incision is made about 1.5mm behind the limbus. Using a crescent knife, I am creating a sclerocorneal tunnel. The corneal end of the sclerocorneal tunnel is about 1.5mm into the limbus. And I inflate OVD into the tunnel area to just delineate the internal lip. This is what we can see. Then using a sharp 2.8 keratome, the internal lip is perforated and then it's enlarged on either side. So the clear corneal tunnel is made now, and time to deal with the anticapsule. Chamber is filled with a cohesive OVD, and my goal is to make a rhexis and then if possible put in a CTR and try to save the bag. But as I'm trying to perform the rhexis, the entire bag is moving and it looks pretty bad. So at this stage, it was very clear to me that saving this bag would be very difficult, and I thought the best option in this case would be to remove the lens in an intracapsular way and then fix an iris clip lens. Because the nucleus would be smaller in this case, I've decided to use the visco-expression technique to express the lens out. So I'm going with my visco cannula, which has got hydroxypropyl methylcellulose, and then I'm just going to inject the OVD under the lens, and the entire lens comes out. So at this stage, I'm sure that the anterior is still not ruptured, and there are two options for me now. Should I perform vitrectomy first and then place the lens, or place the lens and then perform the vitrectomy? So if the anterior is not disturbed and there's no vitreous prolapse, I always prefer to fix the lens first and then do the vitrectomy later on. Simply because when we do vitrectomy, the eye becomes very soft and then maneuvering the lens in and out and visualization would be a problem. So that's the reason why in these select situations where the vitreous prolapse is not there, I would prefer to always place the lens first. So this is the iris claw lens, which is maneuvered into the antechamber. Both the haptics are then placed at 3 nano-clock position. Always prefer to use an hydrodissection cannula to tuck the iris into the haptics of the iris claw lens, and the cannula goes in first, and then I am fixating the lens with my forceps. The haptics go behind the iris, and then these haptics are going to push the iris anteriorly, and then using the cannula I'm just going to tuck the iris in the claw which is there. And once the tucking is done, I'm not going to leave the lens. I'm going to confirm that the iris is really well and truly tucked in the claw. So by moving the lens, I should see that the iris also is moving. If it is moving, then the iris is got tucked nicely into the claw, so you can safely leave the lens. Otherwise, there's always a risk of the lens dropping down. The chamber is refilled with OVD. The hands are swished. Now is the time to fix other side of the haptic to the iris. There is some amount of hyphema in the antechamber. The lens is held with the forceps. The haptics are taken behind the iris, and then the hydrodissection cannula through the side port just pushes the iris down so that it gets enclaved in the claw of the haptic. And you can see this nice pucker which confirms that the iris is tucked well and truly into the iris claw lens. Time to perform an iridectomy. I prefer to do the iridectomy with my cutter itself. So the settings would be IA cut mode, that is irrigation, aspiration and cut mode. The cutting would be reduced to maybe the lowest possible setting in the machine, which would be around 50 or 100, whatever the machine would have. Foot pedal 2, we have the aspiration which holds the iris, and then a couple of cuts, which is by pushing the foot pedal to 3, we initiate the cutting, which would be about 1 burst of cut or 2 bursts of cut, and we usually have a nice iridotomy. Through the iridectomy hole itself, I'm performing just a little bit of vitrectomy there, and then I go in from the main incision, go below the optic of the lens, and then perform an anti-vitrectomy, clear off all the debris, both the lens debris and the blood which should have seeped behind the lens. The glow of the macula doesn't seem to be very healthy. I'm expecting maybe a macular atrophy in this patient because the red glow is not looking very healthy. So once the OVD which is behind the lens is taken care of, then the OVD in front of the lens is also taken care of. The pupil looks to be round and it looks good. So time to close. The side ports are hydrated. The conjunctival flap is closed with quattro. I'm not going to use any suture here because the sclerocorneal tunnel is very well formed. And these are the first day post-op pictures. There is some amount of hyphema, and I just added hometropine eye drops along with the topical steroids. The pressures were under control and the clot progressively reduced, and by the 10th day she was doing fine. Her vision was not great simply because of the macular pathology. She had a chororetinal atrophy in that patient, but nevertheless the patient was symptomatically much better and she was happy. That was it. Thank you for watching and hope you found this helpful.